Hi, let us read about pharmacologic alternatives to blood transfusions. Pharmacologic agents to stimulate production of one or more types of blood cells by the marrow are commonly used. The following is the examples of such pharmacologic agents. First one is growth factors, second is erythropoietin, third one granulocyte colony stimulating factor, fourth one, granulocyte macrophage colony stimulating factor. Fifth one, thrombopoietin. We will see one by one. Growth factor. Recombinant technology has provided a means to produce hematopoietic growth factors necessary for the production of blood cells within the bone marrow. By increasing body's production of blood cells, transfusions and complications resulting from diminished blood cells, example infection from neutropenia or transfusions, may be avoided. However, the successful use of growth factors requires functional bone marrow. Second one, erythropoietin. Erythropoietin, epoetin alpha, example epogen procrit, is an effective alternative treatment for patients with chronic anemia secondary to diminished levels of erythropoietin, as in chronic renal disease. This medication stimulates erythropoiesis. It also has been used for patients who are anemic from chemotherapy or zidovudine (ASD) therapy, and for those who have disease involving bone marrow suppression, such as myelodysplastic syndrome (MDS). The use of erythropoietin can also enable the patient to donate several units of blood for future use. Example, preoperative autologous donation. The medication can be administered intravenously or subcutaneously, although plasma levels are better sustained with the subcutaneous route. Side effects are rare, but erythropoietin can cause or exacerbate hypertension. If an anemia is corrected too quickly or is overcorrected, the elevated hematocrit can cause headache and potentially seizures. These adverse effects are rare except for patients with renal failure. Serial complete blood counts (CBCs) should be performed to evaluate the response to the medication. The dose and frequency of administration are titrated to the hematocrit. Third one, granulocyte colony stimulating factor (GCSF). GCSF, filgrastim neopogen, is a cytokine that stimulates the proliferation and differentiation of myeloid stem cells. A rapid increase in neutrophils is seen within the circulation. GCSF is effective in improving transient but severe neutropenia after chemotherapy or in some forms of MDS. MDS is myelodysplastic syndrome. It is particularly useful in preventing bacterial infections that would be likely to occur with neutropenia. GCSF is administered subcutaneously on a daily basis. The primary side effect is bone pain. This probably reflects the increase in hematopoiesis within the marrow. Serial CBCs should be performed to evaluate the response to the medication and to ensure that the rise in white blood cells is not excessive. The effect of GCSF on myelopoiesis is short. The neutrophil count drops once the medication is stopped. Fourth one, granulocyte macrophage colony stimulating factor GMCSF. GMCSF, sargrammotism leukin. Leukin is the cytokine that is naturally produced by the variety of cells, including monocytes and endothelial cells. It works either directly or synergistically with other growth factors to stimulate myelopoiesis. GM-CSF is not specific to neutrophils as in G-CSF, thus an increase in erythroid RBCs and megakaryocytes platelet production may also be seen. GM-CSF serves the same purpose as G-CSF. However, it may have a greater effect on macrophage function and therefore may be more useful against fungal infections, whereas GCSF may be better used to fight bacterial infections. GM-CSF is also administered subcutaneously. Side effects include bone pain, fever and myalgia. Fifth one, thrombopoietin. Thrombopoietin TPO is a cytokine that is necessary for the proliferation of megakaryocytes and subsequent platelet formation. Clinical studies have demonstrated efficacy of TPO in the setting of chemotherapy-induced thrombocytopenia with few side effects. Further studies are ongoing to assess the efficacy of TPO in other more chronic conditions associated with thrombocytopenia. Researchers continue to seek a blood substitute that is practical and safe. Blood substitutes previously tried have not been successful. However, newer blood substitutes focus solely on oxygen delivery as an RBC substitute. Current blood substitutes in clinical trials have distinct advantages and disadvantages compared with human RBCs. They are manufactured hemoglobin solutions that can be sterilized without destroying the blood substitute. They require no refrigeration and appear to have long shelf life, possibly 1 year, versus little more than 1 month of PRBCs. Perhaps more importantly, they require no cross-matching because there is no RBC membrane to interact with antibodies in the recipient serum. The most significant disadvantage stems from the blood substitutes extremely short life within human circulation, approximately 1 day, instead of the 30-day lifespan of conventionally transfused RBCs. Therefore, the use of these products would likely be limited to situations in which the need is short-term, example surgery and trauma. Finally, the blood substitutes are likely to be extremely expensive. Thank you.